A deceptive episode, convulsive syncope in the guise of status epilepticus. Convulsive syncope and epileptic activity can be difficult to distinguish in a clinical setting. In convulsive syncope, there is at times global hypoperfusion to the brain, leading to the syncopic episode, followed by convulsive movements. These convulsive movements can easily be mistaken for epileptic activity. We have an interesting case here of a 23-year-old male who works outdoors as a landscaper, who was brought in by EMS after a syncopal episode followed by seizure-like tonic-clonic activity, requiring emergent intubation in the field to protect airway, in addition to being started on a propofol infusion. The patient's past medical history was significant only for morbid obesity and a habit of excessive consumption of energy drinks, up to 3 to 4 cans of Red Bull per day. On arrival to the ED, initial vitals showed hypotension, fever, and tachycardia, combined with initial labs that showed a leukocytosis, a lactic acidosis, and an elevated procalcitonin. A sepsis alert was triggered, and the patient was started on broad-spectrum antibiotics, blood cultures collected, and resuscitated with IV crystalloids. Initial EKG, which can be seen in Figure 1 in the ED, showed a monomorphic Y-complex tachycardia, also a prolonged QTC. The patient was loaded with amiodarone and then started on a continuous infusion. He was also given 2 grams of IV magnesium. It was around this time that it was noted that the patient continued to have convulsive-like movements. He was then treated with additional AEDs, given this high suspicion for seizure-like activity. He was loaded with Keppra and then started on valproic acid, and ultimately was on a midazolam infusion to break what was suspected at that time as seizure activity. He was transferred to the ICU for further care. Over the next few days, as the workup returned, the blood and urine cultures showed no growth, no signs of infection. MRI of the brain was unremarkable, showed no signs of leptomeningeal enhancement. An echocardiogram of the heart revealed a normal ejection fraction and no structural or valvular abnormalities. A lumbar puncture performed did show elevated opening pressure, however, was otherwise unremarkable without any signs of infection. The patient also had a long-term EEG, which did not show any seizure-like activity. On day 3 of hospitalization, the patient was on a low-dose beta blocker to prevent further episodes of the tachyarrhythmia and was extubated successfully. During his stay, he was followed by several different interdisciplinary teams, the electrophysiologists, the neurologists, the infectious disease, and critical care specialists. It was ultimately determined that the patient's seizure-like activity was in fact convulsive syncope due to the Y-complex tachyarrhythmia, which in his case was likely secondary to an excessive consumption of energy drinks combined with outdoor work, leading to hypovolemia. In Figure 2, you can see that upon treatment of the tachyarrhythmia, all EKGs afterwards showed normal sinus rhythm. The key takeaways in this case is that on a differential, when we have a patient who has convulsive or seizure-like activity, if there is an tachyarrhythmia or a situation of sepsis, we have to keep our differential broad and keep in mind that there may be a convulsive syncope and not any actual epileptic activity. This could prevent the unnecessary addition of any anti-epileptic drugs and associated side effects. In literature, there is some findings that show that monomorphic ventricular tachycardia can sometimes be associated with convulsive-like episodes. However, the literature is very sparse regarding this.